All right, Dr. Rastogi, thank you. We're going to talk now about the genetics of kidney stones. We're interested in this for a long time because we've been members of the Rare Kidney Stone Consortium. We'll talk about how to make these diagnoses and some of the disorders that are particularly of interest because they have therapeutic implications. We'll look at some of the causes of kidney stones from a genetic point of view. I told you before about the exposome, taking those exposures. They're filtered by this box, our unique characteristics. We could relabel that box the genome, deciding what diseases we might have. So I mentioned heat as an example. Some people are exposed to heat, sweat a lot, don't get kidney stones, and some people do. So there's clearly a genetic component to kidney stones, and I'll show you some of the data supporting that idea, and talk about this middle box at this time. The Rare Kidney Stone Consortium was funded by NIH from 2009 to 2019 and still exists. At the Mayo Clinic, Dawn Milliner, John Liskey, and David Sass have been part of every project, but particularly the experts on primary hyperoxaluria, dent disease, and David has been putting together a registry of patients with CYP24A1 mutations. At NYU, Lotta Baralasic and I studied dent disease, and I was the principal investigator for the cystinuria group. And our colleagues in Iceland, Vidar Edvardsson, Ron Paulson, and Hilda Ronaldsdottir are the experts on APRT deficiency, adenine phosphorybosyl transferase deficiency, a cause of dihydroxyadenine stones. These are the classic hexagonal crystals seen in patients with cystinuria. And I had one opportunity to see that under a microscope and say, this patient has cystinuria. Our review of these four types of stones was published in Pediatric Nephrology in 2013. And I point this out here. If you're interested, all of these four diseases are reviewed here, not really out of date, except for the topics that John will talk about with respect to primary hyperoxaluria, still useful from the point of view of how to make these diagnoses and how to treat these patients. But what about the general population? This is how you do a twin registry, and this is something that we did a while ago. This is the Vietnam era twin registry. It's all veterans and therefore all men at that time. Only men were included in that registry. That's different, I'll show you in the next twin study. But at that time, you basically, the idea here would be that you look at twin 1 and twin 2 and divide the twins into groups. Both members of the twin pair has this disease, kidney stones. That's A. One member does not have it, and one member does have it. Those are the discordant pairs, B and C. Eliminate the twin pairs that are not affected at all by kidney stones, and then you can calculate a concordance rate. So A, the number of pairs where both members of the twin pair are affected, divided by the affected twin pairs, A, B, and C. That's a concordance rate. And so we published this in Kidney International in 2005 and demonstrated that the monozygotic twins, in other words, the genetically identical twins, had a concordance rate of 19%, compared to the dizygotic twins at 9%. This was highly statistically significant and suggests, according to the calculations that the twin researchers make, that heritability accounts for 56% of kidney stones. I think these are the best data demonstrating that kidney stones in the general population are heritable. Now, we don't know what the genes are that are responsible, just like if we could show the same kind of results for hypertension or diabetes, we would not know all of the genes that contributed to that heritability. Environmental effects were considered 44% responsible for these effects here. But it was definitely an issue that this twin registry was only men. We were very much interested in demonstrating whether this was true in women as well. And so we published this in KI Reports in 2019. This is the Washington State Twin Registry. It's done at Washington State College. And we looked again at concordance rates. The monozygotic men had a rate of 68% compared to the dizygotic men of 41%. So we reproduced our previous findings in the VA Twin Registry. And now we showed for the first time, and there's a typo here, this is the dizygotic women over here. You can see that the monozygotic women were 43% of concordance compared to 21% in the dizygotic women. The twin researchers make some calculations and show that the heritability here is 46% in women, 57% in men, almost exactly the same as we had shown in our previous twin study. And this is different. It basically suggests that kidney stones are somewhat less heritable in women than they are in men. So that's interesting. And Lotta Baralosic and I have a review looking at some of the issues. Why are men and women different from the point of view of kidney stones? But we don't really know which genes account for this interesting finding. So this leads me to mention missing heritability. That's the failure of a genome-wide association study to account for the heritability of a trait. So if you looked at the genetics of patients, and we go back and look at this twin study, heritability is 56%. I can tell you that we don't know what the genes are that make kidney stones so heritable. And I mentioned that you would be able to demonstrate a similar finding in patients with diabetes and hypertension. Highly heritable, but the genes are not accounted for. So that's what's meant by missing heritability. We really consider this a heritable disease, but we don't have the genes, even from the couple of genome-wide association studies that have been done for kidney stones. We don't know how to account for this high rate of heritability. Vizzoli in Italy wrote this editorial to look at some of the factors, some of the monogenic factors causing kidney stones, and going through the nephron, basically skipping, as I like to do, skipping the glomerulus, really not an important part of the nephron. Let's get right to the tubules. The calcium sensing receptor, phosphate transporters, clotho, aquaporins, a variety of other anion exchangers have been associated with kidney stones. And there are some data to show some families or affected individuals, but these are not generally found in the general population. There's alkaline phosphatase, there's a protein involved in calcium flux, other anion exchangers. I mentioned some of these, TRPV5 and some channels that are responsible for ion transport, and a variety of other molecules related to a variety of proteins present in the kidney. All of these are potential contributors to heritability of kidney stones, but none of them account for that missing heritability, that 56% heritable value that we showed in our twin registries. A lot of interesting renal physiology comes out of these kinds of studies, but it doesn't necessarily account for the heritability in the general population. This is a study from Hildebrandt's group in Boston, at BU and Harvard. Diane Braun looked at the prevalence of monogenic causes in pediatric patients with kidney stones. They took patients who had at least one episode of kidney stones or an ultrasound diagnosis of nephrocalcinosis, and then looked at a genetic panel to see how many diagnoses they could make. There were 16 cases out of the 123 with kidney stones, and 8 out of the 20 with nephrocalcinosis who had a variety of genetic mutations that accounted for their disorder. So we think that this is a potential strategy in patients, and as the price of genotyping patients goes down using this kind of genetic panel, it will become more likely that we'll make some of these diagnoses. The demonstration here from that same paper was that some of these patients had early onset within a year of age of the diagnosis of nephrocalcinosis or kidney stones, and a group of others had greater than 1 year. And here are some of the molecules that I talked about. OCRL is responsible for Lowe's syndrome. There are claudins here. This is proton ATPase. There are molecules responsible for cystinuria here. There's a variety of molecules that have been associated with monogenic causes of kidney stones. So some of these, maybe 10% conclusion of all kidney stone patients have a monogenic cause, and some of the more common ones include cystinuria. Certainly it's important today, as John Liskey will tell you, to find hyperoxaluria. Claudins associated with magnesium loss and hypomagnesemia as a result. TRPV5 channels were really first suggested by the Icelandic group, the calcium sensing receptor, and the CLCN5 is a molecule responsible for dent disease, active in the proximal tubule. One other molecule that I think is important because it may be particularly prevalent is CYP24A1. This is a cytochrome oxidase, and it's responsible for inactivating active vitamin D. So you know that vitamin D, of course, is 25 hydroxylated. It's then 1 hydroxylated in the kidney and elsewhere in the body to turn into the active form of 125 dihydroxy vitamin D. Most people don't become toxic with vitamin D because they have 24-hydroxylase, the enzyme that turns 125 dihydroxy vitamin D into 124-25 trihydroxy vitamin D, which is also known as calcitriolic acid. But if you don't have 24-hydroxylase because you have mutations in CYP24A1, you wind up with high levels of 25D because you don't 24-hydroxylate it. You get high levels of 125, and those levels stay high because you cannot inactivate them. So these patients then have active 125D. They have increased levels. If they take vitamin D, they're particularly prone to developing hypercalcemia and increased urinary calcium excretion. The other phenotypic finding will be a suppressed PTH. So here's a patient that I just diagnosed last year. She was 8 years old, had hematuria, was found to have nephrocalcinosis, a high urine calcium, and over the next 18 years, she had 1 small stone over that period of time. She was genotyped because it was available at that time when she was a teenager for CLCN5 and ruled out dent disease. And then she was sent to me by her pediatric nephrologist to follow up with her. And at age 26, she had a creatinine of 1, so that was a good thing. Her nephrocalcinosis was not a bad thing. Her serum calcium, which had been high in the past, was not so high. And her PTH, and this is really a classic, PTH was quite low. So you might think, oh, this patient has hypercalcemia, let's measure the PTH, rule out hyperparathyroidism. Her PTH was suppressed. Finally, we're able to get her genotyped as the Rare Kidney Stone Consortium was genotyping a larger group of patients and demonstrated that she had biallelic CYP24A1 mutation. So it's not clear, her mother and she don't recall that she got vitamin D when she was a child, exactly why she had nephrocalcinosis and high urine calcium and kidney stone as a young person is not clear, but she's doing very well with normal kidney function. Some of these patients get renal failure and wind up with end-stage kidney disease. So David Sass, there's his email, sass.david@mayo.edu, is putting together a CYP24A1 mutation. We are genotyping patients at the Mayo Clinic. You send a saliva sample to the Mayo, and we can set you up with that. You can email David if you know a patient who has CYP24A1 mutations and get them into the registry. Hypercalcemia, low PTH, very often an elevated 125 dihydroxy vitamin D. You can also measure and demonstrate that they'll have low levels of 24-25 dihydroxy vitamin D, a normal metabolite of 25D. So I showed you the slide just to emphasize that some of these are more likely to be found, but they're not likely to make up a large number of cases of the total patients with kidney stones that are out there. We do think that genetic testing has practical implications, and one of the most important reasons may be to find patients with primary hyperoxaluria now, as Dr. Liskey has or will tell you, that there are effective therapies for this disease. The prices are going down continually, and you can email the Mayo Hyperoxaluria Center, hyperoxaluriacenter@mayo.edu if you'd like your patient to get genotyped. There's also a panel done by Invitae. It's sponsored by Reata. It's focused on focal segmental glomerulosclerosis and Alport syndrome, but it will also look at the genes for primary hyperoxaluria, which after all is a cause of chronic kidney disease and progressive chronic kidney disease. There's also a panel done by Natera, a company that's interested in doing this. And for the most part, insurance will usually pay for this genetic screening, at most $350 for that panel to be done. Thank you again for this opportunity. here are my contact information, my email address. If you want to follow me on Twitter, I'm at Wetalite. Of course, you know what that is. That's calcium oxalate monohydrate. I'd be glad to be in touch with you if you have issues, want to get patients genotyped, or talk about kidney stones.